Hello, ladies and gentlemen. Welcome and thank you for joining us for this webcast on orthopedic AnyBody applications for the spine. My name is Tony Petrella, and I'm a U.S.-based consultant with AnyBody Technology. I also have an academic appointment at Colorado School of Mines in Golden, Colorado. I'm joined today by my colleagues from the main office of AnyBody Technology in Aalborg, Denmark, Arne Kies and Pavel Galibarov. This presentation is about orthopedic applications in the spine, and so for that reason I thought it would be worthwhile to just note my background in the orthopedic industry. This connection to orthopedics also highlights the priority that AnyBody places on recognizing and responding to the specific needs of users in the area of orthopedic biomechanics. Referring to the agenda for today's presentation, my colleagues at AnyBody asked me to provide a brief background on the company and the software before addressing our main topic of spine applications. I'll also reserve a little bit of time at the end for questions, and I'll ask you to submit those using the GoToMeeting questions dialog box on the right side of your screen. Please feel free to submit questions anytime during the presentation, and we'll take a few minutes at the end to respond to those. I should also note that the goal of today's talk is to focus mainly on examples of what users have done with the AnyBody software, not so much the details of how to do it. Excuse me. Okay, a little background for anybody in the audience tuning in for the first time. AnyBody Technology started in 2002. The software had relatively limited capabilities at that time, as you can infer from the image at the top right of this slide. But features have been added to both the software and the company at a fairly brisk pace over the last decade. A U.S. corporate office was opened last year, and this year the AnyGate module was released, which provides tools specifically tailored to allow efficient processing of large amounts of mocap data for gait analysis. The AnyBody modeling system is a software program dedicated to musculoskeletal analysis, and it was created from the ground up by the development team in Denmark. As such, the software is completely self-contained, but it certainly has the ability to interface with the tools you already use for motion capture, imaging, finite element analysis, CAD systems, and so on. At the core of the system is the anatomical model, or body model, which is completely open, meaning it can be inspected and modified by the user. An extensive amount of validation has also been published, and I'll address that as we go through the presentation. There's also an application programming interface for making embedded apps. This slide illustrates a typical example of AnyBody used in a gait analysis application. The familiar inputs from a mocap system are used to drive the model, and output forces, both muscle forces and joint reaction forces, are computed by the system. Excuse me. As you can see, the animation on the right also provides visual indicators of the timing and amplitude of various muscle forces. And the same thing is done in the spine. This close-up view of the lumbar spine shows muscle forces exerted during a flexion maneuver. The open model repository that comes with the software includes a broad collection of models for the entire skeleton with appropriate detail to allow greater focus on portions of the anatomy that might be critical for your specific application. These models are all completely open. They're parametric, so they can be scaled to subject-specific anatomy, and they've been extensively validated in the open literature. Specifically addressing the spine, a number of important technical features have been included in the models that focus on the cervical and lumbar regions of the skeleton. These include diverse musculature, the passive stiffness imparted by the disc as well as the important ligaments, facet articulations, and intra-abdominal pressure in the lumbar model. And you can also see by the citations that I've listed here that there have been a number of studies published on the validation of these models. In the context of applications, this slide highlights a collection of several different model examples that have been published by users and some that have been created internally. The ability to simulate important activities of daily living and gain a better understanding of the in vivo biomechanical function is probably the most exciting benefit that the AnyBody modeling system offers. And I think this is especially true in the context of orthopedic applications. Of course, one of the tasks that's most common in orthopedic applications is to simulate the function of an implant in the body. And we do have a contact model that makes this possible. This feature in the AnyBody software is referred to by the name force-dependent kinematics. I won't go into a lot of detail about it here, but you can see a couple of nice examples of the general function of FDK in a hip, and on the right is a knee. And if you look closely, you can see the contact patches that are shown in the tibiofemoral joint on the right there. FDK allows for muscle forces and joint reactions to be computed with consideration for the effects of implant design and placement in the body. You can find more technical details about FDK in some of the previous webcasts that have been archived on our website. I put the link here, but I'll also remind you of that later at the end of the talk. And so I invite you to refer to some of those earlier webcasts if you'd like to get a closer look at FDK. In the spine, FDK is an important tool not only for modeling the contact, for example in the facets, but it also predicts how kinematics will be distributed through adjacent levels of the spine on the basis of soft tissue stiffness or the presence of an implant. The simple example shown here has been constrained to the sagittal plane, and a flexion rotation was prescribed for the proximal vertebra. The facet articulation guides the motion, and the red bar you see in the intervertebral space is a reaction force associated with the anterior translation. The magnitude of that force is dependent on the stiffness defined for that degree of freedom. So if there are position variables in your model that are not known in advance, what FDK offers is a way to resolve those unknown configuration variables in order to enforce force and moment equilibrium in the system. An example of how this will be applied in a full lumbar model is illustrated by these results for a simulation of a dynamic stabilization device. This is a flexion extension exercise in this case, in which the angulation of the whole trunk was prescribed. The curves represent flexion of the individual lumbar levels, and the black line represents the L4, L5 level where the device was implanted. Starting with the graph on the top left, we can see that when there's no hardware present in the spine, the L4, L5 kinematics track closely with the other levels, and the total trunk flexion seems to be more or less uniformly distributed among all of those lumbar levels. Now let's jump to the image in the bottom right for the case where a stiff implant has been put in place at the L4, L5 level. You can immediately see that the black curve for L4, L5 rotation has flattened out, indicating that the device is doing its job to constrain motion at the operated level. And if you look closely at the other curves, you'll also see that the adjacent levels have taken up the flexion motion that was not able to occur at L4, L5. This is an important effect of dynamic stabilization, and it's the FDK feature of the model that allows an accurate representation of this behavior. Now, validation is such an important issue for establishing the credibility of any kind of model I'd like to spend just another few minutes to emphasize some of the validation that's been reported in relation to the AnyBody software. I stated earlier that there have been a number of studies published, and a comprehensive list of all these publications may be found on the website. And I'll provide you with a link at the end of this presentation if you'd like to refer to those. Those studies generally fall in one of the 4 categories I've listed on this slide. It's ideal when we can make a comparison between a model prediction and a biomechanical metric that can be measured directly. But that's not always possible. Of course, indirect validation relates to those cases where metrics cannot be measured directly, such as the comparison between predicted muscle activation patterns and measured EMG traces. In the case of a clinical validation, we might ask, does a model correctly respond to clinical questions for which the answer is already known, for example, from retrospective studies? And lastly, we might compare AnyBody results to predictions from a completely different model, such as a finite element model. Direct validation is still pretty tough in the spine, but we do have the data published by Wilkie and colleagues for direct measurement of disc pressure in a single subject performing a number of different activities. These data are shown in the bar chart by the purple bars. Rasmussen and co-authors used AnyBody to simulate the same activities and compared their findings to those of Wilkie. Since the experimental measurements were in units of pressure, disc pressure, and the AnyBody results were based on reaction forces in the different levels of the spine. This is focused on L4, L5, I believe. Both data sets were normalized to their respective magnitudes in the standing posture. So that's what you see on the y-axis of this plot, the percent of these results relative to standing posture. And if you look across all these different activities, you can see the agreement between the AnyBody predictions and the experimental measures is really outstanding. And the fact that the fidelity is there across so many different activities really highlights the robustness of the predictions. And let me just take a moment to remind you that we'll take questions throughout the presentation. Please use the questions dialog box from the GoToMeeting dialog on the right side of your screen. And feel free to submit those at any time during the presentation, and we'll take a few minutes at the end to address those. Now back to the idea of validation. More recently, Galibarov and colleagues have focused on validating the model for passive intervertebral stiffness at the level of a single functional spinal unit. They compared AnyBody results to data readily available from a validated FE model published by Meyer and co-authors. As you can see, the torque rotation curves from the AnyBody model agree quite well with the published data, both for the disc stiffness alone and also with the full set of ligaments included. This model represents the high level of detail that's currently available in the AnyBody model repository. And for the cervical spine, we do have some unpublished data from Mark Disease Lab at Aalborg University demonstrating good agreement between AnyBody predictions and EMG measurements for muscle activity during a lateral flexion maneuver. Subject-specific modeling is another technique that can be important for many orthopedic applications. Here you see two different AnyBody models. To the left is the standard 50% European male, and to the right is a patient-specific model that's been created using basic anthropometric measures and medical image data for the region around the hip. This is a general example that demonstrates the basic idea of how scaling could be done for the whole skeleton. The scaled model has been adapted to match the body size and weight of the patient. And then focusing on the hip region in this example, the geometry has also been morphed to match the measured bone geometry. Notice, for instance, there are significant differences in the muscle attachments around the hip, which of course will affect the results. In the spine, intervertebral bodies can also be scaled individually based on available geometry. And if you refer to the images at the top part of this slide, you can see that if you use mimics for segmenting image data, landmarks can be imported directly into the AnyBody software. But regardless of what software you use for segmenting geometry, AnyBody has options to morph the built-in model to your patient-specific data. So to illustrate one potential workflow for this subject-specific modeling process, we can begin at the lower left of this slide with medical image data from a specific patient. One of the common image segmentation tools can be used to extract the geometry, and then these data serve as input to built-in scaling methods available within AnyBody. We may drive the AnyBody simulation using mocap data or simply prescribing boundary conditions for an activity of interest. And then we can also pursue downstream structural analysis of a certain joint or portion of the skeleton using FEA. And the FEA can be driven by boundary conditions exported from the AnyBody results. And that Simulia symbol there, of course, is associated with Abacus Finite software. If you'd like to learn more about this subject-specific modeling process and details of the scaling options, please refer to the webcast related to the version 5.2 release of AnyBody from late June of this year. This is archived on the website. Okay, so let's talk about some examples of how all these tools have been put together to focus on various orthopedic applications in the spine. As I said earlier, I think one of the really interesting and very effective ways to use the AnyBody modeling system is for computing muscle loading associated with interesting activities of daily living, so that those can not only be used directly for insights into biomechanic questions, but also to drive more focused structural analysis on portions of the skeleton. To this end, Wong and colleagues simulated a simple lifting task as shown on the far left of the slide. And the muscle loads were used to drive an ANSYS model of the L4 vertebra. When comparing muscle loading to the case where reaction forces were simply taken from AnyBody and applied to the superior and inferior end plates of the vertebral body, the stresses computed from the muscle-loaded case were found to be up to 30% greater. And this result highlights the importance of realistic muscle loading for understanding tissue-level stresses in the spine, and that really that's true throughout the skeleton. In a similar study by Gadomski and co-authors, AnyBody was coupled this time with the Abacus Finite software to look at intra-discal pressure during a trunk flexion maneuver. With the Abacus model, muscle loading was compared to application of a pure moment with or without the addition of a follower load. And these results were compared to experimental data previously reported by Sato and colleagues, and also the study by Wilkie et al. That we saw previously. Looking now at the bar chart, let's focus on the L4, L5 results for which there are experimental data. You can see that muscle loading produces much better agreement with the experiments and provides a more conservative basis for potential implant design applications compared to those simple pure moment loading scenarios with and without the follower load. So the pure moment with and without the follower load is sort of the more historical loading scenario that's used frequently in a finite element study. And these results help us to gain some insight into the fact that those loading conditions probably are not as realistic as we'd like them to be. In another study pairing AnyBody with the same Abacus model, Gadomski and co-authors looked at increases in annulus fibrosus stress as well as disc pressure when lifting a 15-kilogram load. You can see there were substantial increases in both metrics for both axial rotation and lateral bending, but the axial rotation was notably worse. This study makes a nice example of how the modeling tools can be used to gain valuable insight for a variety of orthopedic applications and maybe even clinical management of relevant spinal conditions. Excuse me. In another biomechanical study, Andre and colleagues used AnyBody to investigate the behavior of the scoliotic spine. And I've taken an excerpt from their results that I thought you would appreciate because I found it particularly intuitive. I'll be referring to the three skeletal images on the right part of the slide. By varying boundary conditions, they were able to achieve a better understanding of why scoliosis patients typically exhibit axial twisting of the spine together with the characteristic coronal plane curvature. When the rib cage and thoracic vertebrae were allowed to align themselves free of the sternum, there was little or no gross twisting of the trunk, as you can see in the middle image. But when the constraint provided by the sternum was present in the model, an obvious twisting occurred that's even apparent in the alignment of the skull, as illustrated by the result on the far right. So these results agree quite well with clinical experience, and in fact, you could say they represent a certain form of direct validation of the modeling system. Thinking about orthopedic implant design, the potential detrimental effects of altered spinal stiffness have been a topic of study for many years, whether it would be an increase in stiffness due to fusion or a decrease in stiffness associated with a total disc replacement. Upsetting the natural load transfer in the spine is suspected to lead to problems. Belabarov and colleagues looked at the impact of fusion at L4, L5 on adjacent segments during a simple trunk flexion maneuver. They found that intervertebral loads were intervertebral loads were notably increased distal to the fusion, but a more compliant fusion construct did mitigate that effect. This is generally in agreement with the current prevailing belief that a dynamic stabilization device can be more efficacious than a rigid structure. Fukui and co-authors also looked at muscle loads during trunk flexion, and with a two-level fusion in either the thoracolumbar zone or the lower lumbar region, they found that the multifidi muscle forces were increased, particularly in the case with the lumbar fusion, as indicated by the green curve on the graph at the lower right of this slide. Dendorfer, Roby, and colleagues have also reported on modeling studies that predicted increases in multifidi muscle forces. In their studies, they were looking at a loss of stiffness in the natural disc due to herniation. As indicated by the flowchart in the center of this slide, their findings are consistent with clinical observations of notable muscle atrophy in the multifidi. That atrophy is thought to be associated with the state of overload to which those muscles are subjected following a disc hernia. As illustrated in the bar chart on the right, the worst increase in muscle load was observed during axial rotation. Therefore, if weakened multifidi muscles destabilize the spine in axial rotation, this could be an important consideration for implant design to treat disc hernia. I think it's also interesting to note the importance of axial rotation is consistent with the earlier findings that we just saw from Gadomski and colleagues who were reporting on changes in disc pressure in a lifting maneuver. So there's a recurring theme in these data highlighting the demand that trunk rotation places on the spine. And I think that's consistent with what you probably knew. Let's switch over now to the sagittal plane and look at some work reported by Sakamoto and co-authors who investigated kyphosis due to T12 compression fracture. They used simulation to study the compensatory posture observed in these patients, and that posture is illustrated by the AnyBody model on the top right of the slide for the kyphosis condition. Although the kyphosis posture resulted in decreases in several muscle loads as shown in that bar chart on the left, intervertebral reaction forces were increased at the fracture level and below, suggesting an increased risk of adjacent level fracture for these patients who, in most cases, already suffer from osteoporosis, which is probably why they suffered the compression fracture in the first place. So taken together, this study and those on the previous slides tell the familiar story that load transmission through the spine is definitely a delicate balance, and disruption of normal spinal stiffness or stability at a single level can be expected to produce adverse effects at adjacent levels. These are things that I think you probably knew, but I wanted to highlight that this is what the modeling results are telling us, very consistent results with what we have found for the last decade. Total disc replacement is another subject of interest in the spine community, and numerous modeling studies have been reported. DeZee and colleagues used AnyBody to look at the sensitivity of intervertebral reaction force as well as facet force as a function of disc placement as represented by the location of the center of rotation between the fourth and fifth lumbar vertebrae. They found that both metrics were pretty sensitive to positioning of the center of rotation, and lateral positioning was the more important, as you can see indicated by the red zones on both of the response surfaces shown on this slide. Zander and colleagues used a probabilistic approach based on latent hypercube sampling to study not only disc placement but also the number of discs used in a single patient. Lumbar lordosis was reported as an indicator of spinal balance and stability. As you would expect, when there are more implants used in an individual patient, uncertainty in device placement produces a substantial increase in the uncertainty of spinal stability, or lordosis, as reported in this study. And as you can see this very clearly in the box and whisker chart, where with 3 implants, the variability in the lordosis angle is pretty large. Not focused on any specific type of implant, Bresnahan and co-authors were interested to study the impact of muscle damage due to surgical intervention in the lower lumbar zone. Without going into too much detail, they reduced cross-sectional area of affected muscles and then reported on changes in total muscle activity predicted by the model. They did observe notable changes in trunk muscle activity due to this surgical intervention that damaged some muscles. But I think what is most interesting to note is that the greatest impact, again, was seen in axial rotation and lateral bending, findings which are, of course, consistent with the results from several of the earlier studies I described. Again, highlighting what you probably already know, that coupled motions involving axial rotation place a greater demand on the spine. And we have another study related to the effects of muscle damage that comes from one of our internal demo exercises. And here you can see in the image on the left, the red muscles represented damage that was associated with a unilateral approach to the spine. And then in the charts on the right, you can see that as the muscle damage was increased, or the muscle strength was decreased to reflect damage, the compressive force at L5S1 was decreased, and as those muscles were removed from the model, the shear load at L5S1 was increased steadily. Now, of course, I'll point out that the y-axis on those two graphs is different. So it does, in fact, the increases in shear force are somewhat less dramatic than the decreases in compressive force, but that could be an important amplitude of shear force to cause complications at the L5S1 level, which is already probably one of the levels that has the greatest risk for showing symptoms of low back pain. Now I'd like to conclude with just a few studies related to ergonomics, which is a popular application for folks studying spine biomechanics, probably due to the high prevalence of low back pain in pretty much every culture worldwide. Rasmussen and colleagues have looked at seating in the workplace in an effort to understand how seat parameters control comfort and fatigue. The response surface illustrated here relates L4, L5 reaction force to the seat pan angle and seat friction, and generally found that the behavior of the system was rather complex, as I think the response surface kind of indicates. And there was no obvious optimum solution. That is, there were trade-offs between comfort and fatigue. And in a later study focused specifically on driving, Majid and colleagues found similar results from using a similar modeling approach. Although they did suggest that a reasonable balance between comfort and fatigue could be found by modestly reclining the seat surfaces about 20 degrees and also ensuring there is some stiffness in the accelerator pedal to provide support for the lower extremity. Gruzicik and co-authors also studied driving, and they went even further to propose a so-called long-distance driver fatigue function based on muscle exertion and reaction forces acting on the body, both the normal forces and shear forces. This study does look to me to be challenging to validate, but it highlights the versatility of the modeling tools and provides just another example of the diverse ways that AnyBody models have been employed for practical impact, especially in ergonomics and biomechanics. Some other ergonomics applications include the all-too-common lifting tasks as exemplified by this study from Wagner and Reed. And there's another study that was published by Gia and colleagues in the construction field where they sought to influence optimal design of prefabricated wall panels in order to reduce the risk of folks who are assembling those walls and having to lift those panels. And there's another example by Pontanier and colleagues who were looking at best practices for meat cutting. And lastly, Nakashima and Komura have even looked at spinal loads during pregnancy. And I might just note that their AnyBody predictions for erector spinae muscle activity agreed rather well with EMG measurements taken from an instrumented male graduate student you can see in the picture there on the top right. I'm sure that that student now has a greater appreciation for the burden that his female counterparts must bear. Okay, so to summarize, we've highlighted a number of examples of how the AnyBody software has been used for patient-specific models to investigate orthopedic device design and evaluation, to consider surgical planning, to investigate basic biomechanics and device interaction with the body, and in ergonomics applications for automotive, workplace, and also activities of daily living. Now, I've included a number of citations throughout the presentation. If there were any that you wanted to get a closer look at, I'll leave you with this final slide where I've included the link directly to the publications portion of the AnyBody website. And you can see the other links there at the top for your reference. This will be our final webcast of 2012, but we'll be back with new material in the first quarter of 2013, so please stay tuned, and announcements of those webcasts will be forthcoming very soon. And lastly we will have representatives of AnyBody at pre-ORS and ORS coming up in January in Texas. So please feel free to stop by or contact us if you'd like to learn more.